Hi, all right, so now we're going to be talking about the knee and the related structures, and I'm just going to briefly talk about a little bit of the anatomy, but for the most part, we're just going to be going over range of motion and special tests and stuff today. So from the anatomy, one of the things, remember we talked about sesamoids in the foot. The biggest sesamoid is this guy right here. This is called your patella, also known as your kneecap. But in this class, we're gonna call it the patella, okay? And the patella, remember sesamoids, they don't actually fully articulate with another bone. They're encapsulated in a tendon. So you have your quads that come down and form a single tendon, kind of like what we had for the Achilles. So they come together and form your superior quad tendon, and then they run over your patella, and then they come all the way down and together as a conjoined tendon insert on your tibial tuberosity. So your tibial tuberosity is a protuberance that sticks out on your proximal tibia, and that's a really important site because we can get injuries here. One of them is Osgood-Schlatter's that you'll hear about in the other video. We can get avulsion fractures from there, but the biggest reason why you need to know it is because it's the insertion point or insertion site for your quad tendon, and this part is called either your inferior quad tendon or your patellar tendon because it helps attach your patella to the place or to the tibial tuberosity. Then we just talked about the quads. You guys need to know the muscles. So we have 4 quads. Of those, you can only palpate 3 of them, okay? So we have this guy on the inside, straighten that guy out. And this guy on the inside, I kind of call it your biker muscle. This is your vastus medialis oblique, and it's on the inside. Medialis means medial, right? And then on the outside, we have our vastus lateralis, so lateral, it's out here. And then we have our rectus femoris. And we've talked before about uniarticular and biarticular muscles. Both of these guys are uniarticular, but our rectus femoris is biarticular. It inserts down here on the tibial tuberosity with this conjoined tendon, but it also inserts all the way up at your hip. And when we get to the hip, we're going to talk about the AIIS, the anterior inferior iliac spine. And so it goes all the way up there. So it helps with hip flexion and knee extension. But your quads are in the front, they're on the anterior side, and their main purpose is knee extension. Okay, we got that? So then down here we have the tibia. Up here, our big bone is the femur, and then the patella. The fibula, remember, is our lateral bone. And so remember, I always talked about how do you orient yourself? Are you looking at anterior, lateral, medial, posterior? Make sure you're looking for these anatomical structures to figure out what you're looking at. And then if you'll hop up for me. The other muscle structures that we have are the hamstrings. So pull this up for me. So for the hamstrings, we're going to have 3. There are 3 total hamstrings. The one that comes down on the outside, curl up a little bit for me. Bend your knee. There you go. Push up against me. The other way. Like bend. Don't let me push you down. Hold. Don't let me push you down.
Oh, don't let you push it.
So right here, this guy that sticks out with the tendon, this is your biceps femoris. Then we have 2 medial hamstrings, and we have the semimembranosus and the semitendinosus, 2 of them. The tendinosus has a really long tendon, weird, and the membranosus has a really big membrane or muscle belly. All of these muscles do knee flexion. So knee flexion is bending your knee up like that. They also are all biarticular muscles, so they cross and they come all the way up and they insert on your ischial tuberosity, which is the bone that you sit on. A lot of people call it your sit bone. So they come up across your hips. So they also do hip extension. So that's hip extension and knee flexion together. That's what your hamstrings are gonna help with, okay? And then we've talked before about the calf muscles. So we have the gastrocnemius, we have the lateral head and the medial head, and then the soleus that sits deep to that. And all of these muscles, so the gastrocnemius can help a little bit with that knee flexion as well, and it can also help with that internal-external rotation of your knee. Go ahead and sit down for me again. So again, quads, knee extension, when you kick your knee all the way straight, hamstrings and your calf muscle, or specifically your gastrocnemius, are going to be knee flexors. We also have some other deep knee flexors in there that we can't palpate, or well, we just can't see on Charlie anyway. And then remember, we do have a fourth quad muscle, and it lies deep to all of these, and it's your vastus intermedialis. You cannot palpate, and palpate, everybody needs to remember, means touch. It's underneath these, so they could say that it hurts really bad, but basically you have your femur, and then the intermedialis lies right there, and then all the other muscles lie right on top of it. So, and also injury to that one isn't very common anyway, but you guys need to know where it is. The other things that you need to know as we're looking at this is you guys need to orient yourself. We have lateral and we have medial and we have ligaments in here. The outside ligaments that we can touch, remember ligaments are all about stability, are the medial collateral ligament that runs on the medial side of the knee and the lateral collateral ligament that runs on the lateral side of the knee. The medial collateral ligament is huge. It has multiple layers to it and it's really wide. And it takes up this whole inside part. The lateral collateral ligament is a really skinny dude. It comes off your lateral femoral condyle, which is like the knobby thing, and then it comes all the way down and it inserts on your fibular head. Very small dude, okay? And then the MCL is this whole inside part. And part of the reason why we have such a big MCL is most of the time when we're doing sports or just walking around generally, a lot of the stresses we take are to come to the inside. When we do this stuff, so like that, where we compress that lateral side and then we stretch the medial side, that's called valgus stress. And because most of the stresses we take, like if we're gonna push off and cut, that's exactly what we do with our leg, we need to have extra support here to protect that. If we go the opposite way, where we're going, and really nobody ever does this unless like they're tripping and falling, but where you go to the outside, this is called varus stress. And varus stress stretches out the outside, so the LCL. So varus, force comes here and it's coming out, so we're gonna stretch the LCL, and valgus is the force is coming from lateral to medial and it's gonna stretch out the medial side or the MCL. And this is gonna be important to know for mechanisms because we have lots of different injuries that happen especially from the valgus stress, and then also for special tests. And then we've already talked about before, genu valgum and genu varum. So you guys need to understand all of those different positions. The other one is internal and external rotation of the knee, and really it's just of the tibia. So if we're gonna do internal rotation, it's gonna come in like this, and external rotation is your foot's gonna go to the outside. Now, your femur should not move at all. Charlie does not have a whole lot of internal and external rotation in his leg. So when I do it, it comes out like that and in like that. So external rotation, and you guys, I want you to do it. Put your fingers behind your knee. When you go into external rotation, you should feel that biceps femoris get really tight, right? And then when you do internal rotation, you should feel that semimembranosus and semitendinosus get tight. You should have those tendons kind of stick out. So that should give you an idea that the biceps femoris helps with external rotation, and the medial muscles, remember the semimembranosus and tendinosus, happen with internal rotation. So they're contracting when we're doing that stuff. So technically rotation isn't a major thing, but that's why we call it a modified hinge joint. The knee is the only modified hinge joint we really have, because it does allow for some of that rotation. It's not just straight up and back like we saw at the talocrural joint, okay? What else? Ligaments, we can't really touch the ACL and the PCL, but the ACL is going to insert on the anterior aspect of the tibia, and the PCL will insert on the posterior aspect. Also, that back kind of weird fatty part of your knee that sits between your tendons, that is called your popliteal fossa. And that's important because one, we can get a pulse in there. So remember how we talked about if I have an injury, I need to be able to check my pulses distal to that. So if I have a femur injury, if I need to check an actual pulse, not just cap refill, I can try to find my popliteal pulse, that back here in my popliteal fossa. But we also have muscles in there and nerves and everything else. So it's a good structure for you guys to know. Okay, so then from a functional anatomy thing, we already talked about extension. Let's do extension again, and flexion. So extension is considered 0, and then flexion comes all the way back, and it's about 140 degrees as we do that. Then we just talked about the internal and external rotation of the tibia, but again, we call it happening from the knee as well. And we already talked about varus and valgus stress. Now, we can't make varus and valgus stress happen with our muscles, but that is certainly something that does happen within the body. We do also have something called a screw home mechanism, and this is something like the naked eye sometimes struggles to see. But when your foot is down like this, usually you have a little bit of internal rotation naturally of your tibia, and then as you extend out, what you'll see is the screw home mechanism is that your foot starts going into external rotation, or your tibia does. So you're here, internal rotation, and then as you extend up, it kind of locks it into external rotation. So as we come up, and it's really just the last like couple degrees, maybe 10 to 15 degrees, that you see that kind of rotation. Hopefully you guys can see it rotating a little bit as we do that. So that is called the screw home mechanism, and that happens because our two condyles are different lengths. They're not the exact same length. And so that's going to make your leg rotate a little bit as it gets really close to full extension. We're gonna talk in a little bit, well actually, you know what? We're just gonna do leg length discrepancies right now. So there's two different types of leg length discrepancies. One of them is anatomical, meaning that one femur is longer than the other, or one tibia is longer than the other. So anatomical means the bones are actually not the same length. Sometimes you're born that way. A lot of times it happens because of injury though. We cannot fix anatomical leg length with rehab or strength or anything else. It's just a bone difference. Maybe they could do surgery on it, but that's still not us fixing it with stretching or anything like that, right? Then we can have functional leg length. So if you guys have ever heard of people say like my hips are out or that kind of thing, or people sometimes have like real bad pes cavus or pes planus, that can make your legs look different. But if they do x-rays and actually compare the length of the bones are the same length. It just looks like it because their hips don't look the same length. So they have some kind of rotation or up or downward slip or something else going on. And so we can fix functional leg length discrepancy, okay? So we can fix that one. I cannot make his femur grow though. That's not gonna be a thing, okay? So we need to do measurements to figure out, is it coming from the bone, or is there something going on like in the hips, or did he have some kind of injury with his knee or something, or his foot that we could maybe fix to even things out? And again, there's two different ways we do it. We measure the anatomic one way, and we measure the functional another way. And if you'll lay down on your back for me. So what you do to start is you tell them that you're gonna clear their hips. So you tell them to put their feet flat on the table, and then they pick up their butt. So arch and then back down, and then you tell them to really, really, really relax, and then you pull their legs straight out from underneath them, okay? And then, remember I said that there's two kinds of leg length discrepancies. One of them, we're gonna measure from his umbilicus, which is also called his belly button, okay? But you guys need to know umbilicus. And the other we're gonna measure from his ASIS. So if you guys touch on your hips, you should feel like those bones really stick out, like kind of little bony prominences stick out. You're gonna measure from those. And every time you're gonna measure to the tip of the medial malleolus. Remember we learned about this in the ankle. And what you're gonna do, I prefer to measure with millimeters, centimeters, because it's so much easier than inches, but maybe it's just me. So when we're gonna do functional, we're gonna measure from his umbilicus to his right and his left medial malleolus separately, and then compare the differences. So I find his belly button, and you can tell him, hey, put your finger in your belly button so that way I can find it. And then I measure all the way down, and his measurement on this side, my tape measure got stuck, is at 97 exactly. And then I put it here again, and I go here, oh, you are super even, 97. So from from a functional standpoint, he's the same. So this is functional, what I just did. And the reason why we say it's functional is because if his hips are out of line, the belly button isn't going to move, and so we're going to see those differences. Now, if we're going to look for anatomic leg length discrepancy. We're going to measure from the ASIS because his hips rotate with the leg length changes. So these should be constant. So what I would do is, again, find his ASIS, measure from here, come all the way down, and we are at 85, and then I find this guy, and I come all the way down, and we're at 85 again. So again, good job, Charlie. You have even legs. We don't have to put anything in your shoes or work on flexibility or anything like that. So again, the first one that I did is functional, measuring from the umbilicus all the way down to the medial malleoli on both sides. And the second one I did is anatomical, measuring from the ASIS on either side and measuring to the medial malleoli. And this is important for what we do at the knee, even at the ankle, and certainly at the hips, and then when we think about the back and stuff. So this is a measurement that you guys are gonna have to remember for all of the lower extremity stuff and the spine stuff. So just learn leg length discrepancies now. It's a really good idea. Another one that we can do is called the Q angle. And the Q angle, unfortunately I don't have a goniometer, but I'm gonna explain it to you guys. So you would have them lay down, and you would find the center of their patella from top to bottom and right to left and put a dot in that, okay? And then a goniometer, we've talked about what they look like before. They have the dials with the two guys that come off. You take one of them, the stationary arm, and you run it all the way up to his ASIS, and then you take the other one and you run it through his tibial tuberosity. It should not be straight. Nobody's are straight. You got some messed up legs if it's straight up and down. That shouldn't happen. So they're gonna have a little bit of an angle to it, and people either have an angle this way or an angle this way. And the difference is if they have genu valgum, their knee is going to be to the inside. So as you look at it, they're gonna have this kind of angle. And if they have genu varum, meaning they're more bow-legged, they're gonna have this kind of angle. But either way, they shouldn't be perfectly lined up. And when we look at this, typically we're looking for like 10 to 15 degrees. It can be less than that. I've seen some as little as 5, but it should not be 0. And those are normal. But if they're way greater than that, those can be things that can cause pathologies, okay? So when we start talking about special tests, we need to talk about instability. And we've talked a lot about this. We've talked about how you grade the ligament injuries, right? 1, 2, and 3, and that the main issue or the main reason that we have ligaments is for stability of the joints. So if a ligament gets hurt, a grade, not a grade 1, right? There's no laxity with a 1, but there is with 2s and 3s. If the integrity of the ligament is hurt to a grade 2, which is greater than 10% damage, we're starting to see some kind of laxity, and we're just looking at the difference in the end feel as we're doing our assessments. So with these, the main thing that we look for is anterior and posterior translation, and that's when we're really looking at the ACL and the PCL, but we can also see, so translation, FYI, is when they go like this and this. So if this is my tibia and this is anterior and this is my femur, if I'm like this and my femur goes anterior or my femur goes posterior, that is translation. And the same thing can happen with my tibia as well. It depends upon what's getting hit. If my tibia is locked in place and somebody knocks my femur anteriorly, see that, how I do that? That's different than if somebody hits my tibia anteriorly, because I'm gonna be hurting 2 different ligaments when I do that. What I want you to think about is this. When we talk about the ACL and the PCL, A means anterior, right? Anterior is it cruciate or collateral? Cruciate. People are shaking heads in the room. Cruciate, okay? Because collaterals are on the outside, like collateral damage, side damage, right? So the outsides, the MCL and the LCL are collaterals. The cruciates are the inside. So the anterior cruciate ligament, by the way, you guys need the whole names as well as the acronyms. The ACL prevents anterior translation of the tibia on the femur, and the PCL, posterior cruciate, prevents posterior translation of the tibia on the femur. So remember how I said before that the femur can also be the one that moves and the tibia is what sits in place? So this is where people get kind of confused about it. If the femur moves anteriorly, we're not tearing the ACL, we're tearing the PCL. So what I want you to think about is, it doesn't matter what bone's moving, I want you to think about where the tibia ends in relationship to the femur. So if I'm here and my tibia moves, and it moves anteriorly, I tore my ACL, and my tibia is anterior to my femur, right? Yep. Well, if somebody pushes my femur posteriorly, notice my tibia is still anterior to my femur, so that means I still tore my ACL because the tibia is anterior, okay? So if somebody hits me and my tibia moves posterior, I tore my PCL because my tibia is posterior to my femur. And opposite, if somebody hits me and my femur moves anterior, my tibia is still posterior to my femur, so I still tore my PCL, my posterior cruciate ligament. And this is how we're ending, not what bone is moving. So think about how they're going to be in relationship to one another after the bones move. Don't worry so much about which bone moved. And I will tell you right now, when I write tests and when I talk about this and when I explain stuff to people, I literally do this all the time. So if you guys are taking quizzes and tests and stuff and you want to do it this way, by all means, please do it, because it's going to help you learn it and understand it. I promise. There's no problem in doing those kinds of things. All right, so for the knee special tests, we have several of them. The first ones that we're really going to talk about are going to be our valgus and varus tests, because we talked about the MCL and the LCL first. And when we talk about those, remember the MCL is going to be this medial ligament, and then the LCL is going to be this lateral ligament out here. So when we do these, we need to do these tests two different ways, and this is important, you need to know this. The first way that we do it is with the leg totally straight, so we need it to be flat, okay, in full extension, and then we're gonna do it again with the knee flexed to 20 to 30 degrees, no more than that. When we assess it when it's straight, we're assessing the capsule. Remember, all joints have a capsule around it to help give them support, and then when we flex it a little bit to 20 or 30 degrees, we're assessing the ligament. So we need to make sure that we do it in both positions, so that way we're knowing, is it a capsule injury, is it a ligament injury, or is it both? Because if it's both, it's going to be much more unstable, and we're going to have to think more about surgery or really pushing it on rehab, or how much time do we need to take off, or do they need to be on crutches and a straight knee mobilizer, like what's going on and what do we have to do to kind of fix this stuff so that way they're not going to be getting messed up. So I'm going to have Charlie slide my way just a little bit. I promise I won't let you fall off the table. Okay, and so the first thing we're going to do is going to be the valgus stress test. So remember I said valgus forces, I'm pushing from the outside in. I'm going to compress the lateral side, and I'm going to stretch, put tension on the medial side. And so what I'm going to do is we're going to be here, and you need to tell them really, really, really relax. Relaxation is important. Also, it's really difficult, okay? If you guys have ever had anybody do this, I'm miserable. My athletic trainers used to yell at me all the time. So I'm now the athletic trainer that yells at everybody to relax. There's a couple ways to do this. This is my favorite way though. It's going to depend upon the size of the person, the leg, your strength, your height, and everything else to make this happen. But you need it to be relaxed. And then what I do is I just say, okay, and we kind of come down straight. And if you can, you want to put your fingers right over the ligament. And then I take this hand, because I'm going to push in, and I'm going to push in, and then I'm going to, with this elbow, squeeze in, and I'm going to lean my body a little bit so that my hands don't have to do so much work. I can actually use my body to open up his ligament. Well, actually, remember we're testing the capsule right now. And it should move a little bit, but it shouldn't move very much, because our knees have a little bit of motion in them, but they shouldn't be crazy. And then we're gonna bend it to 20 or 30 degrees, and it's not as much as you think. Like, don't be all the way up here or anything, okay? So we're just kind of here, and then we're gonna do the same thing. And now at 20 and 30 degrees of flexion, now we're testing the ligament. So we're testing the MCL, and we're gonna do the exact same thing, and he stops real nice. Have you ever hurt your knee before? No. Yeah, I can tell, because he has like a very hard end feel, and it's not going anywhere, okay? So then we flip it to test the LCL. So does everybody remember what test that is? It is the Varus test. And when we do the Varus test, we're gonna put our force on the medial side, and we're gonna try to put compression here and traction on the outside, and so we can open up or stretch that LCL ligament. Now, hurting the LCL is not very common. We don't hurt this one very much. So again, hand on the inside, because we're gonna push out. My thumb usually sits right on the LCL so I can feel if it's moving. And remember, when we're straight, when we're extension, we're testing the lateral capsule. And I'm gonna push in, and then you can't really see it, but I'm actually rotating my body a little bit into him to make it happen. And again, super solid. There's really nothing moving. I'm actually moving my body more than his leg is actually moving. And then I'm gonna bend it up to 20 to 30 degrees. And I'm gonna tell him to relax because he's using his hip flexor and he's cheating. There you go. And we're gonna do the same thing, and I'm gonna push with this hand going that way, and then I'm gonna rock my body to the side and see if I can get it to open at all. And super solid. There is no laxity in this thing, and he doesn't report pain, right? No pain. So we have a 0. There's no spraining of either one of these ligaments, which is good because otherwise I'd feel really bad doing this thing. So again, MCL is valgus, LCL is varus stress, and that's the same thing as when we talk about genu varum and genu valgum. So then when we talk about the ACL, the #1 best test to assess your ACL, #1 best test is the Lockmans test. Some people call it the Lockmans drawer test. When we do this, again, remember we just said 20 to 30 degrees is ideal for the varus valgus test. It's the same for the Lockmans test. And people have different ways of doing it. If anybody ever wants to know what mini hands look like, these are itty bitty hands. Playing piano for years and years, it was a struggle bus because it was struggled to hit the octave. So when you do stuff, some people can just hold their leg like this and get a really good shift, and actually it's working on Charlie. Good job, you're super relaxed. But mostly for people, what I have to do is I have to put my knee up underneath their thigh, so that way, in the very distal part, so that way it's supported, and that also helps them relax their quad and their hamstrings and their hip flexors. And then you hold it, you're gonna stabilize, you're gonna wrap your hand underneath behind the tibia, and then it's a straight anterior translation. So we're trying to go like kind of straight up an angle like this. And again, we're just pulling straight up, and he has never hurt this. And if he did, the surgery was excellent, and also there's no scars. So good job that you don't have any of that. All right. So that is the Lockmans test. That is the best, most sensitive and specific test for the ACL. There's other tests that we can do. So one of them is called the anterior drawer test. So again, same idea, you're pulling forward, but now we should be at a 90-degree angle, and you sit on their foot and you wrap your fingers, your index fingers, across or behind, kind of posterior to their proximal tibia, and you just tell them to relax. You put your fingers kind of in the joint line, and you're gonna lean back and just pull real gentle on it. And again, if it's positive, it's gonna shift forward. It's gonna have that anterior translation. So remember what I said in the foot and ankle, whatever they did to hurt it, that's how you're going to test it. And remember I said that if you're gonna have an injury to the ACL, it's gonna be anterior translation of the tibia. So for us to see if it's torn, we have to translate the tibia anteriorly. It's not shifting, he's not complaining of pain, his ACL is fine. Then we can flip it around and do a posterior drawer. So what do you think that's testing? I'm gonna push posterior, PCL, right? Because we're gonna do posterior translation, so I don't even have to move, and I can just push posterior on it. And if it sagged back, if it pushed, if it had any kind of crazy stuff, then what we would see is a positive posterior drawer test assessing the PCL as we do this. You can also do these tests with a little bit of internal rotation or external rotation to assess the different corners of the knee. For the purposes of this class, I especially just need you to know how to do it straight, but it is a good idea, especially if you're going to be a clinician, to understand that there's other variations of it, and that you should be assessing, especially the posterior corners, because those are frequently injured with knee injuries. Then we also have the posterior sag test, and this assesses the PCL. It's also known as the Godfrey's test. This is about the easiest test ever to do. And all you're gonna do, and you should do both legs at a time, is you're gonna have them start just kind of with knees bent, and then there's a couple different ways to do it, but what you do is you take them and you tell them to stay real relaxed, and then you bring them up in the air, and then you just look and see where their tibial tuberosities are. Again, he hasn't ever had a PCL injury, so there's not a whole lot to see here. But if somebody had torn their PCL and they were able to stay really relaxed, the side that was torn, their tibial tuberosity would sag down, so it wouldn't be level, and their patellar tendon would be stretched down a little bit. And so again, that's a really easy test to do to look for PCL tears. And it's a pretty sensitive test, I guess. You can do that one. So then the next ones we have are, you know what, we're gonna do McMurray's first, and then we're gonna do Apley's, because you're already on your back. So I'm gonna tell you right now about the meniscal tests. They suck. They are not good at all about telling you if you have a meniscal injury, period. The best thing to do is have them tell you, you would say, how did you hurt it? So their mechanism of injury is going to tell you. And then you're gonna ask them, do you feel like it giving way or locking, clicking, popping, that kind of stuff? It doesn't have to be all the time, but especially like stairs, cutting, standing up and sitting down, changing direction kind of stuff. If they say yes to all of that stuff, or at least some of that stuff, it's probably a meniscus tear and you should send them for an MRI with arthrogram. Remember what the arthrogram is? That's when we put the dye in. The dye is gonna help because it kind of gets in the crevices so we can see it for sure. But these tests we're about to do, they could have a humongous tear in their knee and you would never know because they're bad. They're not very good. So what you do for these, for the McMurray's, is you're gonna put your hand on the top and you're gonna grab their heel. Remember how we did like the anterior drawer test for the ankle? And then what you're gonna do, and there's a couple different ways to do it, and this is how I was taught to do it. So you guys are gonna learn how I was taught to do it. Okay, ready? So the very first thing you do is you just flex their knee all the way up passively, and then you take their heel and you bring it all the way to the inside, and then, ooh, all the way to the outside. You just had crepitus. I don't know if you heard it, but it was a good one. Did that hurt? Okay. So you would also listen and feel for crepitus. That's a positive test. So again, you just kind of go through here and see if you can feel anything happen. And then what you do is you're going to apply varus and valgus stress as you do this. So you kind of come all the way in. So what am I pushing? I'm pushing. So this is going to be valgus stress, right? And as I come, notice I'm going to take his foot and I'm going to externally rotate it, and I'm going to push all the way through, and then I'm going to come back, and then I'm going to do internal rotation and push all the way through and come back, and then I'll do varus stress, and I'm going to do the same thing. I'm going to do external rotation, and then I'm going to do internal rotation. He doesn't like it very much because he's starting to use his muscles and help me out. And what I'm feeling for is any locking, crepitus, popping, catching, and if he reports pain, then that's going to be a positive test. Again, I'm going to tell you right now, this test is not very good. I've had lots of people have tears and this test not be positive at all, but I've also had this test aggravate people because if they have an MCL or an LCL or anything going on inside their knee, pushing their leg to full flexion and extension and cranking on it like that can also cause them a lot of pain. So that's why it's not a super good test. But that one is the McMurray's test. Now I'm going to have you flip over on your stomach. And now we're going to do the Apley's compression and distraction test. So there's two parts to this test. The first part is the compression test. And remember how we just did the McMurray's, where I did internal and external rotation of the tibia. Relax for me. There you go. And so I'm going to do that, and I did varus and valgus stress as I did that, right? So what I'm doing though, hopefully you guys can see, is I'm pushing down through his leg. So I'm actually compressing the tibia into the femur as I do this. And what I would look for is, as I do it, if he says, oh, right there, or if I feel a click or a pop, or he says pain or something like that, I would stop. And then what I would do is I would flip my hands around. So he's like, right there, that hurts, don't press on it. And I would push down on his distal femur. And then you gotta relax there, Charlie. Yep. And then I'm going to distract. I'm gonna pull up on his tibia. I don't know if you guys can see his foot coming towards the ceiling, but that's distraction. And what should happen is his pain should go away if it hurts. So the compression test is going to be positive if it elicits pain. And then the distraction test is going to be positive if it makes it feel better. And if those two things are there together, then that's a decent sign that it's a meniscal injury. But again, this test also sucks. It's not very good. And you can do this test and not get any positive stuff. The other thing is, doing these things, same as how I said for McMurray's, you're stretching out a lot of soft tissue things. If they have fractures in there, it could do stuff. If they have osteochondral lesions, so if they have part of like the cartilage that comes off their tibia or their femur floating around in there, it can catch and cause problems. So you can have a lot of issues in your knee and have this particular thing hurt. If you do the compression test and it hurts, and you do the distraction test and it hurts, probably not a meniscus, it's probably something else. So that's what I mean. These particular tests, while they're great and you should have them in your tool bag, they're not the end all be all tests of everything. Last thing I'm gonna have you do is roll over again for me, please, Charlie. And so with this one is we're going to look at patellar motion. So everybody knows that your patella moves around, right? It's not like just this solid thing. So when we have our patella, can you see this okay? When we have our patella, we're gonna talk about lateral translation. So hopefully you guys can see that I'm pushing from the medial to the lateral side. And then we can have medial translation where it comes from the lateral side to the medial side. When people dislocate their patella, it goes out. Like, I've never seen it go medial. I've only ever seen it go lateral. So their patella goes out and it can sit just right here for subluxation. Or I've actually seen people with their patella in their popliteal fossa. Like, it goes sideways far. Often it's somewhere over their LCL though. And that's because the medial retinaculum and everything that's supposed to hold it in place basically goes away. So what you would do, a patellar apprehension test, is you would put your thumbs on the medial border of the patella and then very gently push or translate the patella laterally. And if they dislocated their patella, what's gonna happen is I'm gonna start pushing, and then Charlie would contract his quad because he doesn't like it, and then would pull it back into place. So that's called an apprehension test, because you're trying to move a bone in a certain way that to them, their body's gonna be like, whoa, that's what just happened. And so they're gonna contract muscles to prevent you from being able to do that. When you do this test, do not get in there and like haul and just like crank on it, because one, you might make it dislocate, and two, your patient is never gonna talk to you again. It's a really bad idea. So really gingerly go lateral. You can also come medial, and then we can do superior and inferior mobilizations of it as well. One of the things that we can do if we think that we have chondromalacia, which is softening of the cartilage, honestly, it's a junk term. Remember how we said MTSS is a junk term? Chondromalacia is a junk term. So if you ever actually have a physician tell you have chondromalacia, just kind of roll your eyes, because this doesn't actually tell you what's wrong with your knee at all. They're just telling you that so that way you shut up and go home. So, but to test for this, and this can be problems with like your superior quad tendon, what you would do is take this part of your hand and you're gonna kind of gingerly wrap it around the very superior part of their patella. And what you're gonna do is not push super hard, but you're gonna say, okay, I want you to contract your quad, and it should pull their patella up. And you say, relax. And then you would push a little bit harder, go. Okay, relax. And then push a little bit harder, go. And what you're looking for is, for one, for them to start guarding, so that way they're gonna stop contracting their quad because it hurts, or they're gonna report pain, or you're gonna hear like a clicking or feel grinding, crepitus stuff going on in there. And then that can be an indication that either they have a quad tendon problem, or that they have some kind of malposition going on of their patella. And so we can work on strengthening exercises to try to even that stuff out. Okay, I think that covers most of our knee valve stuff. So I'll see you in the next one.